Okay, so good evening, everyone, and sorry for the delay to get the translation working, but now you should be able to listen to me in Italian as well. So hi, my name is Kevin Gilmann, and I work at the Moorfield Eye Hospital in London and for the Swiss Glaucoma Research Foundation as well. So before I start, I would like to thank Professor Cusumano for the very kind introduction and thank the Macula and Genoma Foundation for inviting me to speak today. And above all, I would like to thank you all very much for being here today and listening to this talk. So I hope you find this interesting, and I will actually be talking about a slightly different topic from the one you've heard before, because this topic is about glaucoma. Glaucoma is quite an important topic because it is actually the very first cause of irreversible blindness in the world. I will just be holding that microphone, otherwise it's not working. So it is the first cause of irreversible blindness in the world. And the focus of my presentation today is how we use contact lens sensors to actually change our understanding of glaucoma and hopefully change the way we manage glaucoma in the future. So as I am aware that glaucoma is not the main topic of today, I will start with a little introduction of about glaucoma in general, just to remind you all of what it involves. So glaucoma, as you can see very clearly on that diagram, is a very complicated disease and quite a complex one. It is actually so complex that we don't fully understand the pathophysiology of it. So just to summarize very, very clearly and very easily glaucoma, here if you can see this diagram, you will see all the layers of the retina, which you have already seen in previous talks today. And today, in previous talks, we mostly focused on the layers of the photoreceptors, the layers very deep in the retina. And about glaucoma, one of the specific characteristics of glaucoma is it is actually a disease of the ganglion cells. I will try and skip this. Oh, there we go. Thank you. So it is a disease of the ganglion cell that you can see circled in red here. And these cells are the cells that extend with their axons through the optic nerve to bring the information that you see to your brain and allow you to actually see it properly. And in glaucoma, one of the characteristics of glaucoma as well is that pressure is causing stress, is causing damage to these retinal ganglion cells. And gradual damage and gradual stress on these cells is causing these cells to die prematurely. And as they die, they will cause visual loss. What you can see on the left-hand side of the screen is a visual field. Everything that is looking fairly white or bright is what the patient could see. Anything that is looking dark or black is what the patient cannot see. And progressively, as the retinal ganglion cells die because of high pressure in the eye, the visual field progresses. And that is what visual loss from glaucoma looks like. When the high pressure in the eye is treated, either with eye drops or surgery, we relieve the pressure and the stress on the retinal ganglion cell stops. However, any loss of vision from glaucoma is, in the current state of things, irreversible. That's one of the other characteristics of glaucoma. It is pressure related, it is progressive, and it is irreversible. So I talked a lot about pressure. I say it is all very much about pressure because what you can see on this graph here is actually the risk of developing glaucoma depending on the pressure in your eye. And very simply put, what this is showing you is that when the pressure in your eye is above 30 millimeters of mercury, your risk of developing glaucoma is 40 times higher than if your pressure was below 15. Normal pressure in the eye are often considered being between 9 and 21. So as you can see, 30 is fairly high. So the risk of developing glaucoma is very much linked and related to the pressure. This is exactly why all the treatments we have in glaucoma, whether they be eye drops or surgery, all target the pressure, because the pressure is, in the current state of things, again, the only modifiable risk factor for glaucoma. So this is what we treat and it is what we monitor. So you may wonder, why is glaucoma not so simple? Because it is all about controlling the pressure and making sure the pressure is nicely in range. Well, that is what we're going to see just now. And as my colleague, Professor Kusumano, just hinted, this is a presentation about intraocular pressure fluctuation. So this is a little hint about why it is not so simple. All the research about intraocular pressure fluctuation started when some of my colleagues decided to look at what happened while we sleep. And I'm not just talking about the cat in this picture, but I'm talking about the intraocular pressure again. And the intraocular pressure while we sleep actually goes up. And what you can see on this graph is that intraocular pressure during the nighttime, which is a gray area on the right-hand side, go up, and it goes up even higher when you have glaucoma. This is a red line on the right-hand side. So why does this matter? And does it really matter? Because if we've only just found out, and glaucoma has been with us for years and years and years, is it really an impact of this pressure going up while we sleep? Well, that's what some of our colleagues decided to try and find out. And what they've done is they have looked at different factors, different parameters of these intraocular pressure variations. And they have looked at whether these parameters, this fluctuation, actually have an impact on glaucoma progression, on loss of vision in glaucoma. And what they found is that these parameters of fluctuation, all the fluctuation we can see over the course of a day, are actually more predictive of glaucoma progression on visual loss from glaucoma than a single reading we get when we come and see the doctor and check the pressure. So variation may actually have a greater role than simple intraocular pressure reading in determining whether glaucoma is getting worse or not. And some of that is actually related to the effect of the body position. So what some of our colleagues have found as well is that intraocular pressure actually rises by 1.4 to 8.6 millimeters of mercury between sitting and lying down. So when you lie down, the pressure can go up by up to 8.6 millimeters of mercury. And this is quite a lot. And that is actually even greater in older patients and in patients with glaucoma, which really points out at the fact that intraocular pressure and dysregulation of the intraocular pressure is a characteristic of glaucoma. So now regarding the effect of the position of the body during sleep and the effect it has on the pressure, what they have found is sleeping on your side actually has an effect on the pressure, brings the pressure up. Sleeping on your tummy also has an effect on the pressure, and having your neck flexed or extended, just like on the picture here, has an effect on the pressure as well and brings the pressure up. So once again, does that really have an impact on glaucoma? Does it really matter? Well, a very interesting study in patients who've got asymmetrical glaucoma, meaning that glaucoma was worse in one eye than in the other, has actually shown that patients tend to prefer sleeping with their worst eye down. So they prefer sleeping on the side where the glaucoma is worse. And what we have found as well is that that side also tends to have higher pressure. So this is really suggesting that the side on which we sleep or on which we prefer sleeping actually has an impact and is correlated to the rate of progression of glaucoma and may actually cause glaucoma to get worse more quickly in that eye. That's quite an interesting finding I found. But we talked a lot about sleep and body position and when we're lying down at night and all of that. But is that really the only time when the intraocular pressure varies and fluctuates? Well, some colleagues looked at the impact of yoga and yoga position on intraocular pressure. And what they found is this very specific position, if it's coming up, I'll try that again. There we go. Sorry about that. This very specific position, which is called Sirsasana yoga position, which is the one where you got your head down and your feet over your head, actually doubles the intraocular pressure. So your intraocular pressure is multiplied by 2 when you actually got your head down and your feet over your head. And some other studies have looked at other yoga positions, and they have found that to some extent, all of these yoga positions have an impact on the intraocular pressure. So is it really just yoga? Well, no, actually, in fact, a lot of different studies with different modalities and different ways of analyzing things have found that anything you do really has an impact on intraocular pressure. And that includes, once again, this is stuck. There we go. And this includes resistance training, so weightlifting. This includes alcohol consumption. This includes playing wind instruments, stress, meditation, or even sexual activities. And quite an interesting study I found, because sadly it is very relevant to our current days and age, is this study looking at the effect of face mask and wearing a face mask on the intraocular pressure. And all they did really is get patients to wear an FFP2 mask and walk around. And what they have found is that walking around with an FFP2 mask on actually brings a significant raise in the intraocular pressure. Not a very large one, only by 1 to 2 millimeters of mercury, but still a significant increase in intraocular pressure compared to wearing a normal mask, like a surgical mask or no mask at all, which I found quite interesting too. So just looking at the significance of this all, that means that when a patient comes to our clinic and check his intraocular pressure and we're happy with the pressure, and they come back again and again, and we are always happy with the pressure, we can be actually falsely reassured, because maybe when the patient is not with us, the intraocular pressure may actually be doing this. And what one of my colleagues, Professor Tony Realini in the US, tends to say is controlling glaucoma based on just 3 intraocular pressure reading when the patients come in clinic 3 times a year is very much like trying to control diabetes by taking 3 random glucose through the year, but not really knowing what the glucose is doing the rest of the time. It is exactly the same with glaucoma and intraocular pressure. And that may actually explain, if you remember that same diagram I showed earlier about the risk of glaucoma, why 50% of patients being diagnosed with glaucoma actually have normal intraocular pressure at diagnosis. So when they first come in clinic and they are diagnosed with glaucoma, their pressures are normal. That's half of the patients. So maybe part of the answer is what the pressure actually does when they are not in clinic. So what can we do about this? Because now we've found that all these pressure variations are quite important, but how do we find out about them? Well, there is one technique, which is home tonometry, which is basically just checking the pressure like you would do at the ophthalmologist, but checking it yourself at home. And there are different devices, including the iCare Home, which you can see in the big picture in the center. And all of these techniques are available, but they can be quite expensive, sometimes a bit cumbersome, as you can see the one on the left-hand side. And as we've explained, pressure tends to vary when you're doing different activities or when you're sleeping. And you can't possibly be taking your intraocular pressure with these devices while you're sleeping, and not necessarily while you're doing different things at home in terms of doing sports or playing instruments or whatever. So different techniques exist, and one of them is a Sensimed triggerfish contact lens sensor. And this is one of the lenses that was used for a lot of the studies I've presented earlier in the first part of this presentation. And this contact lens is basically like a contact lens you would wear for your vision. It is just a little bit thicker. And you wear it for about 24 hours. And it has what we call a strain gauge, a little ring around the edge of the eye that will measure subtle fluctuation in the ocular volume. And these subtle fluctuation actually reflect fluctuation in intraocular pressure. So it is worn for 24 hours, as I said earlier, and it does measure this fluctuation every 5 minutes for 30 seconds continuously. So it looks like this when it is worn, because the contact lens also needs an antenna that is stuck around the eye, and it needs a recorder, which is that black box on the picture that is attached to the patient's belt. So it is a bit cumbersome as well, so it may impact on the daily activities, but it's only worn for 24 hours. It does reflect very well the intraocular pressure variations. However, something that has to be borne in mind is that it doesn't give the intraocular pressure per se. What it gives you is just a fluctuation of the intraocular pressure expressed in an arbitrary unit. So it does look like this. This is one of the recordings, and in there you can see very clearly that the pressure goes up around 11 o'clock in the evening, right around the middle of the chart, which is when the patient goes to bed. So it goes down around 1 in the morning when a patient gets up for an hour or two, goes back up again when the patient goes back to sleep, and goes right down around 8 in the morning. So you can see very clearly when the patient is sleeping and when the patient is awake, and you can see all those variations. What this doesn't tell us is what the pressure really is when the patient is sleeping. It just shows us that the pressure is rising. And to make up for that defect, the fact that we don't really get the exact reading of the pressure when the patient is sleeping or whenever we want to know it, the company is coming up with a new device that actually has got an actual reader and pressure sensor in the middle that does give us real intraocular pressure readings. And this will become available relatively soon. We have tested it in Lausanne in Switzerland. It seems to be working very nicely, but it will only be available commercially pretty soon. Just a quick word, because we've mentioned that contact lens sensor that is very useful for diagnosis for 24 hours, but it's not very useful for patients who want to know what their pressure is doing on a day-to-day basis on the long term. So for that, there are some different devices that are more permanent, like the Implanted Sensor, which is this time an implantable sensor that you can implant either during cataract surgery or during glaucoma surgery. The picture on the left-hand side and in the middle are little rings that are implanted behind the iris during cataract surgery. And the one on the right-hand side is a scan of a newer generation device that was implanted during during glaucoma surgery within the sclera. That's what you can see on the right-hand side between the arrows. So this counts 16 pressure sensors. This is a picture of the device here, and it really measures the pressure inside the eye whenever you want it. So the way it works, the patient just has a handheld device that just looks like a TV remote, and they hold it in front of their eye, and they press a button for 2 seconds whenever they want, and then they can read the pressure on the device. And that can be used as many times as you want, and there is no battery inside the implant. So it's implanted in the eye and just stays there forever, and it is powered by the remote control that's being held outside the eye whenever you want to measure a pressure. It's quite an interesting different kind of technology. So we're getting to the end of that presentation. So just to summarize very quickly what I've just said, intraocular pressure is the main risk factor for glaucoma progression. But intraocular pressure is very dynamic and is really influenced by anything you do, any activities, any life choices. This is stuck again. These variations actually play quite an important role in glaucoma progression, not just the pressure itself, but the variations of it. And in the future, I foresee that telemetry, so the recording of intraocular pressure variation over 24 hours, will actually play a much greater role in the management of glaucoma. But we still need to do more research to find out how exactly we will apply that to clinical practice. So that's it. I hope you enjoyed it, and thank you very much for your attention.